Good evening, everyone. So welcome to the ninth, can't believe it is, it's the ninth annual series of the Voices from the Vanguard lectures. We're so pleased that you've joined us tonight. Dr. Joanne Cono, who's with us tonight from the Centers for Disease Control, is the 37th internationally known expert on health, basic science, or risk communication who has spoken in this series. It's a big point of pride for Dan Colley and me to be welcoming her. Dr. Colley, he's down here in his red vest so you can find him. He's the head of the Center for Tropical and Emerging Global Diseases. And I'm Pat Thomas, and I lead the Health and Medical Journalism program at the Grady College of Journalism and Mass Communication. And we do this together because it reflects our shared interests. We're interested in cutting-edge basic science. We're interested in how science translates into policy and into public health decisions around the world. And we're very interested in community engagement, in what people, real people, know about public health and science. And so we always just enjoy this tremendously. And Dr. Joanne Cono is someone who shares these interests, and so we think it's particularly appropriate that she launch this series. You can see above me the title of her talk, so I'm not going to read that to you. And you can also see in her program that one of the things that distinguishes the world's leading public health agency, the Centers for Disease and Control and Prevention, is its propensity to create extraordinarily long and bureaucratic titles for everyone who works there. And over her 14 years with that agency, Dr. Cono has had many long titles, which I'm not going to read to you either, because I'd rather hear from her. But I do want to say that she has done a great many interesting things on the front lines, and she is now very engaged with making sure that top quality science is what's put to work on behalf of global public health. And then one small thing that I do want to tell you, because I have to confess, I know her a little bit away from this room. And besides knowing that she's a total sucker for old dogs, nice gardens, good wine, African drumming, I will also tell you that she's maybe the only person in the room whose idea of the perfect first date is to go canoeing in an alligator-infested swamp in the rain. But I think that too worked out pretty well for her. So join me in welcoming her to the Voices from the Vanguard series.
Well, good evening, everyone. Am I turned on? Can you hear me? Excellent. Well, I'm so thrilled to be here with you tonight to talk about one of my favorite topics, which is emergency response and outbreak investigations. And I'm very grateful to Drs. Thomas and Colley for inviting me tonight. I'm really thrilled to do this with you. So tonight I'm going to talk about not only global emergency responses, but activities that touch global facets and details around the globe. So even though I'm just down the road a piece, 70 or so miles, and you've had a lot of CDC speakers visit with you, I do want to do a little introduction to the Centers for Disease Control and Prevention. Then I'm going to take you through an anatomy of an emergency response. Then I will share some tales of public health emergency response. And if we have time, I have a video that's hot off the presses, just released last Thursday. I have one of 2 copies in my computer of a video, 3 minutes, that takes you through an emergency response in live action. So the Centers for Disease Control is actually 9 national centers and 2 additional centers. And while people tend to think of infectious diseases when they think about the CDC, and about half of our staff are focused on infectious diseases, we do a lot of other things there too. So you can see we also focus on environmental health, chronic disease prevention, birth defects, injury prevention, occupational safety, and health statistics, as well as global health. And we probably have had emergency responses in all of these areas, except perhaps health statistics. We have about 19,000 people at the centers, and most people are located in Atlanta. However, we do have 330 staff around the world in about 60 countries, and we also have about 1,400 locally employed staff that work very closely with the CDC staff. In addition, on a regular basis, we have staff leaving on emergency calls around the world, and this is a map from last year where we had 347 people sent on an emergency basis somewhere else. How many people in the room saw the movie Contagion? There's a few of you out there. Well, this was a really big deal at CDC. They did come and visit with us. Kate Winslet was in the hall outside my office. I wasn't there that day. I was in Washington, D.C. But everybody else had their picture taken with her. But she did a really great job of portraying one of our disease detectives, which is the Epidemic Intelligence Service, the EIS fellowship program that many of you have probably heard of. Some of the science in the movie was a little shaky, but she did a great job. The other thing that they did a really good job of capturing was sort of the social chaos that might happen in a big outbreak, and we've spent a lot of time thinking about that at the CDC as we prepare emergency response plans. So 9/11 and 2001 really changed the way we focus on emergency response. Prior to 9/11, we did this in a very sort of mom and pop way, where Joe Plague might have gotten a phone call at his desk, and they were reporting to him that there was a suspected plague case somewhere, and he would go down the hall and knock on his friend's door, and they would say, "Oh, we have an outbreak of plague, let's get together and do something." Now we have very formal channels that do this, and I'll talk more about that as we move on. Another thing that's changed the way we handle emergency responses is this map and the flight patterns around the world. So these are the flight paths, and in the past, from the year 1800 to the current time, we've had a 1,000-fold increase in travel. And that's not probably too difficult to imagine. And 1.4 billion people travel by plane every year. So not only are people, food, products, insects, plants, pathogens are moving too. So how does CDC do its work? Well, presuming us at the middle as the premier federal public health agency, we touch a lot of different groups, and some of them might have been expected and some of them may be less so. So, of course, we work with laboratories and other federal agencies like FDA or NIH, hospital systems, other health departments, state and local health departments, universities, national organizations, professional organizations. But you may be a little more surprised, and this is newer to us too, is that we also interact and consider our partners to be first responders. These are firefighters, police officers, EMTs, all the other people that keep civil society running smoothly, and we incorporate them into our emergency response planning. The other group that we rely more heavily on recently are also private physicians and private veterinarians. We are always keen to have an astute clinician see something and report it to us, and that's how we identify a number of outbreaks. Our global partner is the World Health Organization, located in Geneva, Switzerland. The World Health Organization has authority in public health around the world, and there are 194 member states. Now, one thing the World Health Organization doesn't have so much of is resources. And so one thing that CDC helps to do is we supply personnel and expertise in some of their worldwide activities, and we'll talk more about that as we get on. One thing that WHO has been very good at promulgating is the international health regulations, and this is also something that's been newly updated. So the international health regulations are a way to notify emergencies around the world, and so it was first written in 1969, but then wasn't updated until 2005, and most recently has been updated in 2011, and now we rely very heavily on this. So all the member states, the United States included, are required to report all public health emergencies of international concern. And there is a detailed algorithm that we use to decide whether or not we're going to report something to WHO. And I would say about once a month, I am called to a council to sit with a group of scientists to say, is this worth reporting? And it more recently was expanded to go beyond infectious diseases to include biological, chemical, and radioactive nuclear events and natural disasters. And then in addition, we also are required to report some standard diseases that may not surprise you. So smallpox, polio due to wild-type virus, SARS newly added, and human influenza of a new subtype. Another reporting mechanism that CDC has is the CDC Health Alert Network. And you can go online to this website and see the reports that we put out as a needed basis around the United States, and they're often picked up around other parts of the world as well. And this is a way for us to quickly disseminate emergency information very widely. And it goes out through a listserv as well as gets posted on the internet. And you can see one of our recent advisories of this past fall about the Group B meningococcal outbreaks at Princeton University. So I said that we really changed the way we do emergency response work, and one of the changes has been the use of an emergency operations center. So this is a way of bringing professionals from across CDC together in one place to work together as a team to figure out an outbreak. The other thing that we now do in the Emergency Operations Center is we function under something called an incident command system. And this is very much what firefighters or the Department of Defense might do in an emergency situation as well. So there's one leader, there's very standard ways of reporting, and it's different from our day-to-day activities. This is a listing of some of the big activations that we have had over the past 10 years, and you'll recognize some of them, and some of them go on behind the scenes, so you might not even be aware. So one that you might not have been aware of is the presidential inauguration. CDC is always there, always has plans for what we would do if there was a public health emergency. But some of the ones that won't surprise you are the polio eradication effort that's going on worldwide right now, the H1N1 pandemic of 2009, Hurricane Katrina, CDC was there doing infectious disease surveillance. So when does CDC get involved? Well, all response is local, and that's our mantra. So the local jurisdictions are the people who know the system, the landscape, the culture, and they also have the authority until they invite CDC and turn it over to us. So we only come if we have an invitation. So even if there was, I don't know, a tularemia outbreak here at UGA, the people that would get the first responders would be the Georgia Department of Health. And it's only if they said, CDC, will you help us, that we would come. Now, sometimes we're engaged with people as they're working through an outbreak, and we might suggest to them, we would be very glad to help you if you would like us to, and they usually very gladly accept that. So what do we do when we do an emergency response? Well, the epidemiological investigation is trying to figure out who has the disease, how do we find it, what are we going to call it, and how do we keep tracing it and count it. The laboratory investigation very tightly partnered with the epi investigation, and this involves the specimen collection, the characterization of the pathogen, and the epidemiologists and laboratorians work very closely together. Then CDC also brings to bear vaccines, medications, supplies like ventilators, respirators, and we also come in and give advice about infection control measures. Should you isolate ill people? Should we quarantine healthy, large groups of people? What are we going to do? We also put a big focus, and all of our response plans have a section on communication. Communication is critical in a large response, not only with the public at large, but with our other partners around the world and with one another. And we'll talk more about that. And then environmental control plays a part very often because we also have to think about toxic exposures in the environment or cleaning up after a biological situation. So now I'd like to run through a few cases with you. Does anyone know what this animal is? This is a civet. And people tell me it's not a cat. It looks like a cat. But this is a civet. And does anyone know what this is? Okay, this is a coronavirus, and we call corona because it looks like a crown. You see the little crown pieces? And this is the pathogen that caused SARS. The SARS outbreak in 2003 was a really big test of CDC's global capabilities. And what I'd like to do is run through some of the communications from that outbreak, because this is 2003 when this outbreak occurred, and the way we communicated with one another is so different from the way we communicate now. So this outbreak unfolds, starts in November of 2002 in Guangdong province, and the government physicians there recommend isolation of patients with symptoms of a respiratory illness. So this is going on in an area of China, and there's some discussion among themselves. In February, so a good number of months later, on ProMed, which you might know as an online emerging infectious disease reporting site, begins to capture reports of pneumonia in China's Guangdong province. About that same time, a medical missionary calls into CDC and reports about 400 deaths from pneumonic plague. And with this information, CDC contacts WHO. We often get these reports that are a little bit off kilter, but they always involve some follow-up. So the next day, WHO China office calls in a report of an atypical pneumonia outbreak, but not a lot happens right away. And then a few days later, China officially confirms an outbreak of atypical pneumonia with 305 cases and 5 deaths. So we're already about 3 months into this outbreak. February 19th, to confuse the situation a little bit, a father and son with avian flu, H5N1, are identified in Hong Kong. And on that same day, because of this H5N1 case, there's a conference call between WHO, HHS, and CDC about the avian flu case. Oh, and then there's also that Guangdong situation. A number of days later, in Hanoi, Vietnam, an American businessman from Hong Kong with atypical pneumonia, respiratory failure, and a history of travel to China and Hong Kong shows up very ill. And a couple of weeks later, as cases start to grow in Hanoi, medical staff in Hong Kong and Hanoi fall ill with the atypical pneumonia. So we have large numbers of people already ill. In early March, CDC learns that the disease has spread to healthcare workers in Hong Kong and Vietnam, following an alert to WHO from Dr. Carl Urbani. Carl Urbani is really recognized in this outbreak as one of the heroes. It was his phone call that turned this situation around and really brought it to attention. He's an Italian infectious disease physician who was working in Hanoi. Vietnam then requests that WHO assistance, and CDC sends a medical epidemiologist to Hanoi. On March 12th, WHO issues a global alert about cases of severe atypical pneumonia in Hong Kong and Vietnam. So this is close to that international health regulation alert that I mentioned earlier, so it's taken a number of months for this to happen. And CDC offers assistance to WHO. And at this point, CDC just pours resources into this, and personnel are arranged on teams, and we're out in the field helping it in any country that requested assistance. In addition, we're also working domestically because we're on alert for cases here in the United States. Well, on March 15th, the first US case is identified, and CDC hosts a briefing to talk about this atypical pneumonia, which is very hard to say, and it finally gets an easier name like SARS. And CDC issues guidance for what the state and local health departments should do to help interrupt the transmission of SARS as we begin to see more cases. And then we also issue a case definition. That's part of the epidemiology, to identify who the sick people are and to give some sort of frame for how we should identify them. And then we also issue a health alert notice for travelers to the United States from Hong Kong and other areas around there. March 16th, we start intercepting people at the airports and handing out health alert cards to passengers who come in. And then finally, on March 24th, CDC's laboratories identify the new coronavirus to be the cause of SARS. By then, we have 39 cases in the United States, and of these, 32 had traveled to the regions where the outbreak occurred. And this goes on for a number of months until July 5th of 2003, when WHO announces that the SARS outbreak has been contained. So this is a map that shows a very interesting situation in this outbreak, and that is the situation of what we call a super spreader. And a super spreader is someone who does an amazingly effective job of transmitting disease. And this super spreader, a Chinese businessman, stayed at the Metropole Hotel in downtown Hong Kong. And he very effectively transmitted the disease to 12 people on his hallway in 24 hours. And then these people took the disease to other parts of the world. So you can see we have been able to trace more than 4,000 cases worldwide to this initial exposure. But the people who left the hotel went to Canada, the United States, Singapore, Vietnam, and Ireland, and got on the plane and took it home with them. Now, I mentioned that civet cat at the beginning, and that's where the coronavirus was found. The civet cat is a reservoir. And these are some of the wet markets in which the civet cats are caged in China. Up in that corner, you can see some of the civets in their cages, but in the Chinese wet markets, live animals of different species are caged together in close quarters under difficult hygienic situations, and that leads to all sorts of pathogen mayhem. So in the end, when the outbreak was contained, we had the disease in 29 countries around the world. We had about 8,000 cases with 700, almost 800 deaths. In the United States, we had 27 confirmed cases and no deaths. And the cost of this outbreak worldwide was $30 billion. CDC's role in the response went on for 133 of these days, with 850 people from across the agency involved. Within hours, we had 112 people deployed on response teams out in the field to the affected countries, and within 3 days, we had 200 people working on this around the clock. And I bring this up because we're not quite done with the coronavirus. Coronavirus also causes the common cold, is one of the causes of the common cold, but it's also currently in another form, the Middle East Respiratory Syndrome coronavirus, or MERS-CoV, has raised its head in the Middle East. And it's not as infectious, but it is quite deadly. And so this is WHO data organized by CDC, and you can see most of the cases are focused in the Middle East, with some transmissions to Africa and Europe. And at this point, this is as of a week ago, we had 182 cases, 79 deaths, with a 43% case fatality rate. So that's pretty deadly, but the good news, it doesn't spread as easily. Now I want to move on to another case. Does anybody know what this little baby has? Cooties. This is a little baby with smallpox. Smallpox is caused by the variola virus. It's an orthopox virus, and causes the disease smallpox, which is a febrile rash illness with about a 30% mortality rate. Fortunately, the World Health Organization declared smallpox to be eradicated in 1980. Smallpox doesn't have an animal reservoir, so by very efficiently and effectively vaccinating people, we were able to put an end to the outbreaks of smallpox, which have been a scourge for centuries. Even longer than that, and have killed millions of people around the world. And in fact, the virus is only held in 2 places in the world right now, one at CDC and one in Russia. And in May, the World Health Assembly will vote again about whether or not we should destroy those stocks. So in 2003, also, well, this is a little bit earlier, 2001, 2002, the United States was involved in military activities in Afghanistan. And at that point, President Bush gave a directive to CDC and said, we're really worried about bioterrorism because we don't know who else may have the virus, and we want you to get the plans together to figure out what we'd have to do if there was a smallpox outbreak. And that involved getting the vaccine in place, getting together antivirals, and making all sorts of plans for all the equipment that would be needed, and beginning to educate physicians and emergency response people in the United States and around the world. The vaccine is a live virus vaccine made from vaccinia, which is a related virus, not the smallpox virus. And in the upper corner, you can see some men harvesting the lymph from a calf where they were growing the virus and making the vaccine. And then the vaccine is administered with a bifurcated needle, very different from other vaccines. This vaccine, because it's a live virus and also used on the surface of the skin, also can cause a number of serious adverse events, so we don't take it lightly that we would use this vaccine. But in an outbreak, the risk of vaccination is much lower than the risk of dying from smallpox. So in the middle of the SARS outbreak, we get a phone call about a baby, a little child, up in Wisconsin who has this sort of lesion on her arm. And she had been bitten by an animal, and they're very concerned about it. It's very hard. It feels like buckshot under the skin, just the way smallpox feels. And remember, we've just gone through this big preparedness for smallpox outbreak. Here's some other pictures of her lesions taken at the Marshfield Clinic. And the thing that's notable about this is that all the lesions look the same. They're all in the same stage of development. And so I was sent on a plane up to Wisconsin to examine the patient and take a look. And in the end, we brought specimens back, and there were specimens at Marshfield as well. And this was identified as monkeypox, which is an orthopox virus as well, but it usually infects monkeys, and we had never seen this in the United States before. But they do see it in some countries in Africa, and it causes brain swelling, swollen lymph nodes, scarring wherever you have the lesions, blindness, and has a 10% mortality rate. And that's all we knew about it, so we were quite worried about this. And went on to identify 30 patients around the US that had monkeypox. We offered smallpox vaccine because it's effective in about 80% of the time. And we also started to do a trace to find out how this happened. And you can see a little prairie dog here in the front. And one of these little prairie dogs bit that little girl who had the first lesion. And we went on for the first time to do an animal investigation as well. And we found that the culprit in this outbreak was something called a Gambian giant pouched rat. Well, these rats were imported from Ghana, and with a number of other exotic animals, came into Texas. From there went to Iowa, mixed with a number of other animals. These animals are called pocket pets. People like these little pets as put them in their pockets when they keep them at home. And then these Gambian rats met up with prairie dogs, which are also kept as pets in people's homes, which was a very interesting phenomenon. And in Illinois, these animals got sent off to Illinois, Indiana, and Ohio, where there were other cases, and then to Wisconsin, where we saw that little girl with her lesion. And then they had quite an outbreak in Wisconsin as well. So this was an interesting situation. It's the first time that we did an animal traceback and an animal investigation. And our veterinarian epidemiologist did a great job with this. So we had the human investigation and the animal investigation going on at the same time. So this turned out to be a great trial run for smallpox preparedness, because we don't have smallpox around, so we can't practice on that. But we did vaccinate personnel who were going to be in contact with the patients and the animals. People got familiar with the vaccine, which was a very good thing. We got to practice our infection control measures. We got to practice our laboratory testing. And we also got to practice our emergency communication. So nobody died, and there was a silver lining here. And there might be an ongoing threat. So outbreaks continue to go on in Africa. And one of the most popular places to release your exotic pets when you're no longer in love with them is Everglades National Park. And I had known that our teams had been down there to do animal investigations in the park. But it wasn't until I was there in January for vacation that I saw the actual signs in the visitor center that talk about the Gambian pouched rats that have been released there and how you shouldn't release your exotic pets. So we might have a little reservoir going on somewhere. Okay, next case. Let me see how I'm doing on time. All right, this is a man with an ugly scab thing on his neck. And then we have a gram stain of gram-positive bacilli. Does anybody have a guess on this one? Anthrax in the back. Yes, this is a man with cutaneous anthrax. Anthrax comes in what we thought were 3 forms: cutaneous, gastrointestinal, and inhalational. Inhalational is almost always fatal, even with treatment. Intestinal, about 50 to 100% fatal with treatment. And then most people recover from cutaneous. Almost everybody recovers from cutaneous. And as you know, anthrax is a zoonotic disease. The spores live in the soil. It's ubiquitous all over the place, but it can kill herds of animals. This is an X-ray of someone with anthrax, and it's a pathognomonic finding for anthrax. So this center part of the X-ray we call the mediastinum, and that's where our large vessels are, and our respiratory system, and our heart, of course. This mediastinum is considered widened, and the reason it's widened is because the lymph nodes that trail up and down that track are swollen hugely. And being aware of this finding helped us be aware of the anthrax attacks of 2001. Because the first patient in Florida was an elderly man with septic disease, and he had this X-ray, respiratory distress, and the physician said, "Holy cow, look how wide his mediastinum is." And that set off the investigation into the anthrax attacks of 2001. And you may recall that that was an intentional release of anthrax put into letters into the mail supply. We have mail sorters. I have beautiful video of this that sort the mail, and when it sorts the mail, it aerosolizes the anthrax spores that are in the envelopes. And we were often running for a number of months with huge numbers of staff all over, trying to track down patients and offer prophylaxis before people became ill. And there were cases in Connecticut, Florida, New York, and then we were doing investigations in a lot of other places where there were scares. So one of the activities we had was also tracing the path of the letters. So we became really close friends with the Postal Service. The Postal Service was greatly affected and very frightened by this outbreak because they're in there working where the stuff was. And so we were offering them antibiotic prophylaxis and vaccine, and then doing this tracing of all the areas where letters may have passed and where we could anticipate illness. So we learned a number of lessons from this outbreak. Communication was so important. This was an intentional release. The fear around this was incredible. Of all the responses I have been in, this is the one where the staff was the most passionate. It was just after 9/11. We all felt under attack, and we all felt sort of this patriotic urge to protect our nation, and the people around the country were just so upset and frightened. And we learned one thing we didn't anticipate is how we were going to deal with the worried well in an event. So we always think about what are we going to do with the sick people, but all the well people show up too because they're really frightened, and we have to have ways to deal with that. We also realized that while we talk about numbers of states that are affected, every state was affected, because even if they didn't have cases, they were all chasing down white powder scares, and they were all really frightened. So everybody had public health activity going on. The other thing that we witnessed for the first time was hoarding, which happened in Contagion, and that was people were hoarding antibiotics in the affected cities. I had phone calls from people I knew in New York saying, "Could you write me a prescription?" And I was trying to assure them, we will be giving away free antibiotics. We don't need to do that. But there was fear about that. And then after an anthrax release, we also have the spores in the environment. There was a lot of environmental cleanup that needed to be done. Now, since then, we've had a number of anthrax outbreaks in the US, and they have all been related to African drums, one of my favorite activities, made from goat skins from Africa. And so these animals have been in the area where the spores are, and then the goat hides are used to make the drum, and in working with them, you can get cutaneous anthrax. You pound on it or scrape the hair off to make the drum surface, and you aerosolize this. So we've had both inhalational and cutaneous cases. In the corner here is a little very authoritative-looking slip that says that the goat hides that have been imported are certified free of anthrax. We don't have any way of certifying hides are free of anthrax, but what we do recommend for drummers is that you get your hides from the United States, not imported, even though people say the sound quality is better from the imported, and that they're chemically treated to take care of anthrax spores. CDC has also been involved in an outbreak investigation more recently in Scotland, where a number of heroin users were ill and died of anthrax poisoning. And I think the final count was about 50 patients and a large number of deaths. But these patients showed up in Scotland, some also showed up in Germany, and as we did the tracing, we found that the heroin for this outbreak probably started in Turkey. It didn't look like an intentional insertion of anthrax in there. We think that the heroin was wrapped in goat skins for the smuggling, and that's the way the heroin became infected or infectious. So now we have another case. I think I'm doing okay on time. This case takes place in New York City, and in Queens, in a 16-mile square radius, all of a sudden there's an outbreak of 8 cases of encephalitis, which is serious brain swelling, and flaccid paralysis, so people are becoming paralyzed. All of these people were previously healthy, and they all enjoyed outdoor activities. And so the New York City Health Department was hard at work trying to figure this out. They thought it might be an arbovirus. Arboviruses are transmitted by mosquitoes, but they didn't quite have the pieces together yet. Across town at the Bronx Zoo, a number of exotic birds had started to die. And in fact, birds were dying around New York City, but they were crows and blue jays, and people didn't notice them. But when the birds at the zoo started to die, they were onto that. And the veterinarians there also were investigating for an arbovirus. And this was in the early days of 1999, 2000, where veterinarians and human health clinicians didn't always talk to one another and didn't always work together. They didn't even think of it. So we were both having these parallel investigations going on. And in the end, this virus was identified. This is the West Nile virus. And it took us a while to find the mosquito, but the virus was actually identified in Connecticut. There are more than 50 mosquitoes that carry the virus in the United States. And the transmission cycle is that the mosquito is the vector, the birds are the reservoir host, and then people or horses are sort of incidentally infected. West Nile virus comes from Uganda. In that upper corner, Aruha, that's West Nile, and it was identified as early as 1937. Now, the interesting thing about West Nile is how quickly it became established in the United States. So here you see that there's just that little nidus around the New York City area, and then it rapidly marches across the U.S. And now it's, and now we consider it endemic here. Now, the reason I bring this up is because we're watching 2 other viruses where something similar is happening. And the first is chikungunya. You may have heard of this virus. We don't usually see it in this part of the world. We expect to see it in the Middle East and some Africa. But this is a virus that causes incredibly achy pains and fever. You just feel terrible. It doesn't kill you, but you wish you were dead. And we've worried about this as a potential bioterrorism agent because it wouldn't kill people, but boy, it would really scare people, and it would overwhelm our health system. So this is one that's it's just spread to the Caribbean, and we're watching it closely, and this is a traveler's alert on the CDC website. Another one that we've been watching closely that we're not surprised about, but there is a big outbreak going on, is dengue virus in Puerto Rico. And that red curve is the current outbreak, and the blue dotted line across the bottom is the historical dengue. So that's a big one to watch. Okay, I have one more case and then we'll be done. And this case is a little bit different. This case is about the Haitian earthquake of 2010. Haiti is the poorest country in the Western Hemisphere, about 10 million occupants, inhabitants, and about 4 o'clock in the afternoon in June of 2010, a 7.0 earthquake hit right outside of Port-au-Prince, which is the capital of the island. About 3.5 million people live in that area. And afterwards, there were 52 aftershocks of at least a 4.5 on the Richter scale. So it was quite a scary situation. And there weren't a lot of resources there to start with. And here you see some of the devastation looking over Port-au-Prince. Here you can see where the earthquake occurred and the aftershocks, and that whole area is quite affected. And here's some of the devastation. Now, CDC's response in this sort of situation is quite different from an infectious disease outbreak. Because there isn't an outbreak, we're not going to go we don't go to pull people out of buildings and do that sort of rescue. We're not even in the position to provide clinical care. We might do clinical assessments. But we go in these sorts of disaster situations to set up surveillance, to look for infectious diseases that might follow. So we were invited down to work with Haiti's Ministry of Public Health, which was decimated. I mean, the people who we needed to count on, their homes were destroyed, their family members were killed. We had one leader at the Department of Health there. The Pan American Health Organization was also partnered with us, and we put 2 systems into place. We looked for internally displaced people, and then we also set up a national Sentinel surveillance system for infectious diseases and other injuries. One thing that came in very helpful was Google Maps. We had to find out where people were and where the best places to set up our systems were. And I found this really fascinating. I want to draw your attention to the bottom series of photos. So the first one is a golf course in Port-au-Prince before the earthquake. And you see how it's all empty and green. The next photo is 3 days after the earthquake, and people are afraid to be in their homes. There's all these aftershocks going on, if they still have a home. And they all fled, or numbers in this case, fled to the golf course and start to set up tents. And then that one is months later, and it looks like it was a city, and it was never a golf course at all. So we chose 51 surveillance sites around the country, and we used our PEPFAR platform. So PEPFAR is the President's Emergency Plan for AIDS Relief, and a very well-funded program and a lot of activity there in Haiti. Also, those employees were facing the disaster, but we were able to build on that platform, and 13 days after the earthquake had the surveillance system in place. And the way we had it flow was from the sites. We're doing this all by telephone because the computer access is really miserable, and paper. It would go to CDC Haiti, where PEPFAR was. Then it would come to CDC, to that Emergency Operations Center, where we would analyze these data. Then we would send it back to the Ministry of Health. They would look at it and say, yeah, thumbs up, because they're in charge. And then it would come back to the CDC, where we would share it more broadly with the public health partners in Haiti, because we had greater capabilities than they had right there on the ground. So this is a little different flavor and a different type of event. So now we've turned that surveillance system over to Haiti, and they're running it now. Now, of course, this was followed by a cholera outbreak, sadly, in October of that same year, and this is an epidemic curve of that outbreak. I'm not going to talk in any great detail about it, but CDC also had staff there for the cholera outbreak, and you can see some of the healthcare situations that were set up and some of the information posters that are written in Haitian Creole. And during this period of 13 months, CDC had 900 people back and forth to Haiti and working on this outbreak. So that's the end of my cases. I wanted to leave you with what we think about expecting the unexpected, and we're always looking out for and appreciate the alert and astute clinician, laboratorian, veterinarian, and the public. We're looking for you to help us track these diseases. The man's photo in the corner is Carl Urbani, who I mentioned died in the SARS outbreak. We're tracking a number of viruses at all times. We are very involved in the influenza, the viruses selected for the next year's influenza vaccine, and played a huge role in the pandemic that I didn't get into here. But it's very high on our list, and one of the most rapidly changing pathogens. Hi.
In cases like the heroin transmitted one, is it your responsibility, or can you not report in order to get information, illegal activities, and how does that work?
That's a great question, because the other place it came up, criminal investigation came up, was in the anthrax outbreaks. So in the intentional in New York City. So in Scotland, we were working with the Health Protection Agency of the UK, and their guidance and the way they publicized this is there weren't going to be questions asked, that safety came first, and health came first, and they did a really nice job of acting on that and publicizing that. In the United States, during the anthrax investigation, what I didn't mention is that was the first time that public health worked alongside the FBI, because we had a criminal investigation going on looking for terrorists, and we had the public health investigation going on trying to protect people's health. Often we were in the same room at the same time trying to interview patients, very different styles, very different cultures. As an outcome of that is that for a number of years after that, we have been running a training course where CDC personnel and FBI personnel get together, and we do little outbreak team practice together. And it's been so interesting and so informative to hear the difference about how criminal investigation is going on, how different it is about what information they'll share, and they're learning a lot from us about how we do public health investigations.
I'd just like to throw in, and you mentioned
Sure.
that about CDC has about 19,000 employees. Well, I think, some of you who may have impulses to do good things, you may think, well, I could never work at the CDC because I'm not a doctor, or I'm not an epidemiologist or a laboratory scientist. Could you talk to us about some of the other sorts of expertise?
Sure.
That we need?
Yeah, that's a great question. Yeah, I think that the scientists get a lot of the out in front attention, but we have industrial hygienists, we have communication specialists, we have IT specialists, we have people that do environmental decontamination. Gosh, anything that you would need to run a business, I think we have at CDC. So there's a role for everyone there. And also there's a number of fellowship programs and summer training programs for people who are interested. For a number of years, CDC was running a night training program, journalism program, to train and prep journalists to report on health events and health findings. And I've taught in that a number of times, and it was always great fun. The journalists had great questions.
How does the CDC use media to track infection epidemics?
How do they use the
How do
media?
they use the media? Like, are they using sources like local sources, or are they just
Yeah.
focused on national publications or anything like that?
That's a good question. Actually, it gets into this whole area of our new way of functioning and something we call situational awareness. So it's not only that information is coming to us, but we're looking out at information. So we may not chase everything, but if we see a confluence of reporting around some activity, that may tip us off in a direction. And we share that information with other federal agencies as well. So yeah, we have lots of We have a special unit that just collects that information and shares it. And during any of these emergency responses, we also set up what we call a JIC, a Joint Information Center. And that center is responsible for incoming communications and outgoing communications. So there's a lot of important communication work that goes on. We've also learned so much about risk communication from these responses, especially the anthrax outbreak. Long gone are the days when a federal official can get up and say no comment. It doesn't serve the public well, and your head will get bitten off. But we spend a lot of time thinking about who's going to be out in front of the camera, what their background is, what they know. We know that whoever's in charge of the response, everybody wants to talk to that person, but that person also has to be leading the response. So we have a number of subject matter experts that can interact with the media and the press. We also learned in the anthrax outbreak, if we don't have a subject matter expert available to talk, the press will find a subject matter expert, whether or not we think they're an expert. And so that can lead to all sorts of miscommunications. So we spend a lot of time in advance, and all of our emergency response plans also come with emergency communication and risk communication information. And many of us have been trained in risk communication and being able to talk with people on the street in these sort of venues in layperson language about what they have to worry about, and more importantly, what we want them to do. In an emergency, people want to know, well, what should I do? What can I do? And we want to have that message ready. I know in this audience there's probably a lot of do-gooders. And so one thing I want to say too, one thing that's really challenging in some of these disaster situations is the flood of volunteers that show up to want to help. And while that's a really noble endeavor, it can be really challenging when we're in the situation trying to manage the disaster victims and set up public health systems to also have to be taking care of the volunteers who came not quite prepared, are drinking the water that's in short supply, and are using the resources. For a year, our CDC staff lived in tents in Haiti. So it took a long time for us to get permanent housing over our head, and the people there are living in tents. And so having volunteers flood the area, although very well-meaning, can sometimes make the handling of the disaster more difficult.